items we're looking to cover. To cover a little bit of the background of the ACA or Affordable Care Act and really this design, some individual responsibilities, what that looks like for all of us, subsidies in the public marketplace, and we'll kind of differentiate a public versus private marketplace. We're going to go through, there's some employer shared responsibility rules that I think are important for everybody to be aware of, along with some market reforms that are having an impact, and individual reporting that you'll actually have to go through starting now, and maybe some of you have already seen some of it based on if you've started filing your taxes, and then just some annual limits and what that looks like at this point in time. And so as we go through kind of the background, I think it's important that everyone is aware that when this first came out back in 2010, the core of the law was to attempt to reduce the number of uninsured in the country. And depending on which study you want to look at and follow, there's a rather large estimate of uninsured, and there certainly was a rather large estimate of uninsured individuals in the country back when the law was passed. And so what they were trying to do is reduce that number and get at it in a couple of different ways, which we'll go through. And one of those is requiring most citizens to have health insurance or have a penalty in place if you do not have the right type of insurance. Create exchanges, or the public marketplaces as they're called now, where individuals can purchase coverage. And if your income is at a certain level, between 100 and 400% of what we call the FPL, or federal poverty level, you would be eligible for some premium subsidies or tax credits. And then it also requires larger employers to offer coverage to all full-time employees, or have the potential of paying a penalty if they did not do so. And then by design, it also was expanding Medicaid to 138% of the federal poverty level, which had been 100%. And actually that was one of the things that was then defaulted back to the states, and the states had some flexibility to expand that or not. But by design, it was to try to help those individuals within the Medicaid environment to raise that level a little bit to, again, try to reduce the number of uninsured that exist in the country. And so when you look at that, one of the interesting things is, and this is why you'll see some of the tax credits or subsidies, as everybody refers to them as, and why they were created. So this is a 2011 report. These percentages really haven't changed too much from that time, but this just gives you an idea when you look at it where the uninsured were coming from. And so what happens is that the largest share, as you can see, are those individuals that are 200% of the federal poverty level or below was the greatest percentage. And then as income rose, so did the likelihood that those individuals were insured. A lot of that coming from being employed and coming through employers. But this just kind of gives you an idea, and this also gives you an idea of, as we look at the subsidies, what those thresholds look like. And so these are 2015 numbers, as you can see on there. And so when you're talking about, up to 400% of the federal poverty level, you can see, what that looks like based on household. And so for a family of four, which is most commonly referred to as, up to $97,000 of household income, in theory would be eligible for a subsidy, but we'll go through some examples because that subsidy amounts decreases as your income increases. Another screen that I think is just important for everybody to kind of be aware of is when you look at healthcare reform or ACA, and as unfortunately we have too many acronyms in the employee benefits world, but when you look at the different, where coverage is coming from, and this was a study that was done back shortly after the law was passed, and some of these numbers have been modified a little bit, but I think this slide does a great job of showing what's going to happen. And so you'll see here from left to right, employer-sponsored coverage, really, while some employers on the smaller side, meaning maybe they have 2 or 3 or 5 or 10 employees, might go without coverage and drop coverage because there are no penalties in place there. For the most part, employers that have been offering coverage are doing so for a reason, and it's anticipated that number to stay relatively flat. But where you're going to see some changes certainly are with these exchanges, or as we call them now, marketplaces. Certainly increase in that, and depending on how closely, again, you follow it within the public marketplace, that number is eking up towards the 9 or 10 million threshold at this point in time. PHI is private health insurance, so there still is private health insurance that's not within the exchanges or marketplaces that exist, and so that will decrease because the thought is most of those individuals will go over to the marketplaces or exchange because they're eligible for the subsidies, but there still will be all those individuals that will have private health insurance. And as you can see there, Medicaid and CHIP is a Children's Health Insurance Program. That's a national program. You see those numbers increase, and again, that folds back to what I mentioned before, and one of the mechanisms to reduce the uninsured was to increase the Medicaid percentage from 100% to the federal poverty level to 138. And then ultimately, the goal would be to reduce the number of uninsured. This particular survey put it at 57, almost 57 million at the time it was done, reducing that down. And one of the interesting things here that I think is important to note is that there has not been a study done yet that I've seen that with this, that means that it's going to eliminate the uninsured population. Even when you look at some of the more recent Congressional Budget Office results that they've done, the anticipation is there still will be somewhere in the neighborhood of, maybe it's not this high, maybe it's less, but somewhere in the neighborhood of 20 million uninsured individuals in the country, even 10 years down the road. And so again, it was the goal is to reduce the number of uninsured, not necessarily eliminate the uninsured population that exists. So individual responsibilities, that kind of gives you a little bit of the background and what they're trying to accomplish when they created health care reform or the Affordable Care Act. But what does that mean for an individual, for all of us that are listening to this today? There are individual mandate taxes that exist. And so what happens is right now as you're getting ready to file your taxes, or maybe you've already started, you will have to verify if you had coverage in place during 2014. The beginning of 2014 was when this part of the Affordable Care Act went into place. And as you can see on the slide here, depending on if you have, it's just an individual or if you have a family, you would pay a penalty for not having insurance of $95 per adult, or 1% of your family income or individual income, if that were the case, whichever is greater. And that number goes up. So for right now, if an individual didn't have coverage in place last year, you can see what the penalty would be for doing that. And then as it starts to get more substantial as you move down the road here, getting into certainly 15 and 16 and seeing what some of those numbers look like. And so that's the individual mandate tax, and that was a key part of the Affordable Care Act, and one that actually went to the Supreme Court back a couple of years ago now, and remained in place is this individual mandate tax. And so that kind of begs the question, if that's the case and I need to have coverage, and this is all done through the tax mechanism. So again, as I mentioned, as you file your taxes, and we'll get to a little bit later as well, but what that means, what do I do to avoid that tax is kind of the next question I think that most people ask. And in order to avoid that tax, individuals have to have what they consider a minimum essential coverage. And that can be attained through a number of different avenues. Certainly your employer, like all of us on the call today, you have coverage available to you through your employer. Medicare, Medicaid, TRICARE, which is for, in the VA, this is for military, individual policies, or an exchange or marketplace. Those are all avenues where if you have that coverage, you as an individual can avoid that individual mandate tax that we just went through. And so the question then comes up is, okay, I see the tax, I know how to avoid that, but coverage, as we all are too well aware of, the fact that it's very, very expensive. And so what if I can't afford the coverage? That's where these subsidies come into play, or premium tax credits as they're officially called. And so what happens is there's, you've seen this presentation, it's called Exchange. They've changed it to Marketplace because it translates a little better within different languages. But what happens is if your income is between 100 and 400% of the federal poverty level, you are eligible for a premium tax credit as long as you can see that last bullet point on there. You do not have coverage to affordable employer-sponsored coverage. So if you, let's say, were an individual and let's say you weren't employed currently, or you worked for an employer that was maybe a smaller or larger employer regardless of size, and they did not offer coverage that was affordable to you, then you would be able to go to this public marketplace or public exchange, and as long as your income was between those thresholds, you would be eligible for a subsidy. And if you were on the lower end of those FPLs or federal poverty levels, you can see on there, there's actually cost-sharing reductions in the way of lower deductibles and lower out-of-pocket maximums if your income is below 250% of the federal poverty level. And so this is a way, it's an advanceable premium tax credit, meaning that if you were to apply today, you wouldn't have to wait until tax time of 2016 for 2015. If you were eligible for a premium credit, you would actually get that advanceable, meaning that you would actually pay a reduced premium to the carrier, whatever the differential was between what your income says you should pay and the actual cost of premium. And so we're going to get into that a little bit more as we go along here as well. So what is a healthcare marketplace? In its simplest form, it really is an entity that is set up to allow individuals to compare healthcare options. As you'll note on there, it is actually not providing the coverage itself. These public marketplaces oversee the options that are out there, but they're not actually providing the actual coverage themselves. And so you've probably, again, depending on how close you follow this, you've seen some differences between 2014 and 2015 as far as carriers that are available here in our area. There are, last year, Anthem was certainly one of the bigger ones in the marketplace that was providing coverage. Common Ground, which is a co-op that was formed out of healthcare reform, actually, was another one in our area. And then depending on which pocket in the state, there were some other ones that were available. And then in 2015, January 1st of this year, they actually, United Healthcare jumped into that arena as well and was providing coverage to individuals within the marketplace. And so then if the marketplace really, again, it's allowing people to compare and does not provide the actual coverage, what are really our responsibilities? They are kind of in a management role. So the carriers, the United Healthcares, the Anthems of the world, actually have to go through a process and then apply to offer coverage within these marketplaces, and they have to follow certain guidelines and rules in order to do that. So that's where the marketplace has some oversight on that. They also are there to provide website and toll-free call center, and the biggest thing that they do is they help determinations of enrollment, meaning that what these subsidies are that I've kind of been alluding to that we're going to go through a little bit more, including cost share reductions and coordinating. There could be a scenario where someone goes to the marketplace and enrolls, and their children actually go through Medicaid, or what we call Badger Care here in the state of Wisconsin, and the individual enrolls in a traditional plan offered by a United Healthcare or an Anthem. It's very possible. And so there's a number of different scenarios. Again, that would be the marketplace's role, is to help determine where that individual fits and what avenue they would go down with that. There are specific regulations within the marketplace that exist, and they are what we call the metal tiers or coverage levels. And so when we talk about these subsidies coming up here, they're based off of what we call the silver level plan, meaning that at 70%, in essence, the plan is designed to pay 70% of covered claims costs. Now, it doesn't exactly work out that way. These are what we call actuarial values, so they're determined that way. But in theory, as you go from bronze to silver to gold to platinum, the platinum plans are going to have your lower deductibles, lower cost sharing than certainly you would on your bronze level. And so it goes up incrementally, but all the plans have to be within very tight percentages of those different levels. So 2% plus or minus. So essentially, the plans really are bronze, silver, gold, or platinum, and they have to be very upfront on that. So if you were to go out to the marketplace, you would actually see plans, and they would say whether they are bronze, silver, gold, or platinum. And again, as I mentioned, all the subsidies are based off of a silver level. So if you wanted to buy up to a richer plan, you certainly could. However, the subsidy you receive would not increase in that mechanism. Or if you wanted to buy down and use that subsidy you received to buy a lower cost plan but cover more of the cost share, you could do that as well by buying down to a bronze level plan. But probably if you've heard people talk about this, they refer to them, like I said, as the metal plans. But that's really what they mean, is the bronze, silver, gold, or platinum. Within the public marketplace, the coverages have to align with those different percentages for coverage. So kind of as we walk down this path here a little bit and are laying this out, the next thing I think that comes up is really these subsidies. I've alluded to them quite a bit, and so I think it's important for everybody to understand kind of what that means and how that works. So you'll see here what this looks like and what these subsidies are. So they're really, as I mentioned before, 100 and 400%. They're advanceable, and so what does that really look like? And so I think we've kind of talked about that a little bit, but I think it's important to take us to the next level because this is where it can, well, Affordable Care Act in general is very confusing, but this is where it gets rather confusing for individuals. What is affordable? I mentioned this earlier, affordable coverage. What's affordable to one person could be very different to the next person, but within the Affordable Care Act, they actually defined what affordable means. And so what that looks like is this, is that a plan is considered affordable, offered through an employer, if the contribution to participate for the employer plan is no more than 9.5% of, and technically speaking within the law it says household income. However, the way it's actually been codified by the IRS is that it's actually based off of the individual's income or box 1 of the W-2 wages. And so what happens is that you as an individual, your actual contribution, so if you participate right now in the medical plan, you would pay, let's just use easy numbers, I'm not going to use actual numbers, let's just pay, say it costs $75 to participate for employee-only coverage. Now it doesn't matter if, let's say I have a spouse and children and I'm enrolled as a family coverage. For affordability purposes, as you can see, it's all based off of the employee-only coverage. And so what you do is you would look at it and say, okay, how does the $75 per month contribution for the plan, and if you had multiple plans, it's the lowest cost plan. So how does that compare to box 1 of my W-2 wages? And if that's less than 9.5% of that, that plan is considered affordable. And so what that means is that it's affordable for me, as you can see in 2013, this went back and forth quite a bit, but the IRS issued guidance and said, if it's affordable for the employee, it's affordable for the family. And so what that means is that if I have affordable coverage available to me through an employer, all that subsidy stuff that I was just going through, I'm not eligible for that, regardless of where my income fits within the federal poverty level. And so this is a big item, and this is why you can see the bullet point on there. This approach really limits the number of family members who would be eligible for subsidized coverage because of the fact that it ties to the employee-only coverage on the calculation of affordability. And so hopefully that makes some sense. I know it's, like I said, it's rather confusing as to kind of the wording and some of the semantics on here, but this is a very big item. And as individuals, and this is where people have unfortunately got caught in a bad spot where you go out and even at Walmart nowadays or within if you go to CVS, there's certified application specialists and assisters that might be trying to help people get enrolled in the public marketplaces, which I don't think is a bad thing because we want people to have coverage. But they ask the question, is the plan affordable? And that $75 might be affordable for one person, but the next person might not think it is. But there is actually an actual calculation that's done to determine that. And so it's important to note that this slide is probably one of the most important slides to understand when you're hearing all this stuff about public marketplaces and subsidies and affordable coverage and everything else that goes on, that this slide is a very big is all the determination on whether an individual is really eligible for those subsidies or not. So household income is obviously an important question. This all ties back to taxes, and really it's modified adjusted gross income. So depending on how you file your taxes, that could mean something different for you. But the thing that's important to note is that it's all members of the household or the family. And so if you have, if you're working and a spouse is working and you have a dependent that you claim as a dependent, and they work over the summer and make $3,000, that would be added in. That would all be tied into this household calculation of income to determine where you fit on that range of that 100 to 400% and how that works. So for example, let's say you had someone that was at $24,000 of household income. That comes down to $2,000 a month. We like to make our math nice and easy. At 9.5%, you can see that comes to $190. So that, what I was just talking about, that $75 contribution, in that scenario for someone at $24,000, that would definitely be affordable. It would actually be affordable all the way up to that $190 number. And if it was above that, that's where it would get into a position where that individual could, even though they had employer-sponsored coverage offered to them, could actually go out and enroll in the public marketplace. And so how does this whole thing work? This is really what the design of it is you must, in order to get a subsidy, you have to apply for health coverage through the public marketplace. They're going to collect your data. They're actually going to collect employer data too, and they're going to try to catch this. And I catch kind of has a bad connotation, but I really think it's a good thing in this scenario because back to the example I was giving a couple of minutes ago, if someone were to apply for a subsidy and received a subsidy, and then it was determined later on that they actually had affordable employer-sponsored coverage offered to them, that individual technically would have to pay back the subsidy they received. And so that would not be a good situation for people to be in because, as you can see that bottom bullet point, if the tax credit does get settled up when taxes are filed. And this also means that, as the first year went through, there was actually a self-attestation as to your income, which had some unfortunate ramifications for individuals because you were saying, I make $24,000, but then let's say a spouse wasn't employed at the time but got a job, or you changed jobs. This all will be settled up at tax time, so it gets a little bit tricky as to the actual credits received. The one thing I will tell you, though, is that unlike other mechanisms the IRS has to go after individuals, they cannot put liens on any of your property you own if you owe back money. The only mechanism they have to take that money back if they over-subsidized you would be as if you're getting a refund or you're getting money back from the IRS. They would be able to offset that, but they cannot. Within the law, they did not give the IRS any mechanism to go after you outside of any refund that might be coming back. So if there is a huge lopsided scenario in there, that is one thing to keep in mind. So I've alluded to this quite a bit as well, and I want to just kind of put a slide. We put a slide together for you so you understand this. So as the whole concept here is, as you make more, you pay more. And so the biggest question that we get asked a lot is, well, what is my subsidy amount? And really, it's all tied to your income. So the actual cost of coverage that the carrier is providing in the marketplace is really irrelevant. You might have, and you'll see in the next slide, depending on your income and what level you're at, that you could have two individuals that, let's say they're going for the same Anthem plan, but one is at 200% of the federal poverty level and one's at 300% of the poverty level. They could have the exact same cost of coverage from the carrier or from Anthem, but they could pay two different premiums to that carrier based on their income level. And so you can see there's that line. If you see it goes from 2% and it kind of stays flat, that's really at that 138% of the federal poverty level that I mentioned earlier. It starts to go up at that point. And so you can kind of see it starts to arch up. And as I mentioned earlier, while you are eligible for a premium subsidy all the way up to 400% of the federal poverty level, once you get to 300, you go up to 9.5% of your income is what you would be responsible for paying for premium. So while you technically still could be eligible, again, you're talking about 9.5% of your income. And frankly, I don't know too many people that want to be paying 9.5% of their income towards health insurance. So I don't know, at some point in time that subsidy kind of erodes a little bit. But certainly down at the 3%, 4%, 5%, 6%, you can see it kind of arches up. That certainly would be impactful to those individuals as far as a premium credit being available to them. So we tried to put together a couple examples to actually make this make some sense. So we just took an individual with a family of 4 at age 30, and then an individual at the same age but single, and so you can see here the retail cost. But the retail cost is really what is the irrelevant part. What really happens here is that based on, and we just use 300% of the FPL in this particular scenario, but at 300%, you can see, it ties back to that slide I just mentioned. And so the maximum premium is what the maximum that the individual would pay. And so you can see, because I have a family, that might actually mean something more than as a single. But at the same time, age has a factor on it, which we're going to get into some market reform and what that means. And so that federal premium assistance, the max premium is the max that individual would pay based off of income. So you can see, a 30-year-old family of 4 with the same income as a 50-year-old family of 4, my max premium that I would have to pay is the exact same, right? Because my income's the same. Same thing for an individual that's age 30 versus age 50. My max premium I would pay is the exact same. However, where the difference is what the actual credit is from the subsidy that's issued out there. So, again, same income for a family of 4 at 30, because my rate is a lot less, I would get $300. Family of 4 at age 50, because my premium is a lot more, I would get $882 in that scenario. But again, it all ties back to income and setting that threshold, and then that's where the actual assistance comes in. And you can see the max out-of-pocket is the exact same for all those plans as well. But what's changing here is the amount that I'm paying versus what the actual amount of coverage is. But it really, for me personally as an individual, it's all going to tie to my income. So let's kind of go through some employer share responsibility rules, because I think this is important for everyone to be aware of as well. We've spent a lot of time on the individual so far, which I think is important, but let's talk about the employers and what their responsibilities are as we go through this new world of the Affordable Care Act. This has been delayed a couple of times, and depending on the size of the employer, it continues to seem to be delayed. But essentially what happens is that as an employer, if you are a certain size, which really 50 full-time equivalent employees is really the number that's used, you are not required to offer coverage, but if you don't offer minimum essential coverage, you face a penalty. And so they also put into place that a full-time eligible employee is one that averages 30 hours a week. That hasn't been as big of a deal necessarily in the state of Wisconsin because of some fully insured rules that have been in place for a long time. But other parts of the country, that's been a rather big deal, and certain entities, let's say hospitality is a perfect one, where you've seen when it all came out, the Olive Gardens and the KFCs and all those companies back in 2010 said we're going to reduce everybody's hours to under 30 hours a week. That's what they were targeting at, is because of the fact that became eligibility for health coverage, whereas maybe it was not prior to that date. And as I mentioned, what is an applicable large employer? There's been some delay on this, but essentially the big thing you can think about is any employer that has more than 50 full-time equivalent employees. So you actually have to add full-time, which is considered 30 hours because of what I just mentioned, and then all the hours of those that work less than that and come up with a full-time equivalent to determine if you are required, I shouldn't say required, if you are responsible for penalties if you don't offer coverage. And so what do those penalties look like? I think is kind of the one big question that gets asked. The $2,000 penalty is probably the most talked about penalty within the press and what you've seen over the last couple of years. So if an employer does not offer minimum essential coverage to all the full-time employees and children, you'll notice in there it specifically does not say spouses. It's been quite an item of contention throughout the Affordable Care Act. There's conflicting rules between what the Affordable Care Act says and what different state rules say, but within the Affordable Care Act, specifically for full-time employees and dependent children, if you do not offer coverage, you'd pay a penalty per full-time employee of, it actually breaks out by a month, but everybody refers to it as a $2,000 penalty, of $2,000 a year. You'll see, not counting the first 30, you actually, it's actually even more than that this year, but you get to reduce the first 30. So let's say you had 75 full-time employees. You wouldn't count the first 30. Let's say you have 70. I'll make the math easier for myself. You'd have 70 full-time employees. You don't count the first 30. You'd have 40 remaining. You'd have to pay 40 times the $2,000 in a way of a penalty for not offering that coverage. There also is a second part to that, that even for those employers that do offer coverage, if the coverage is unaffordable, which we kind of spent some time on that prior, or it doesn't meet the minimum value, which is the metals that we talked about, so that bronze level plan, if it doesn't meet one of those thresholds, then there's actually a penalty that exists that's higher. That would actually be $3,000 per year. However, it would only be assessed against those individuals that went out to the public marketplace or exchange and received a subsidy. If that was the case, and we kind of went through the mechanisms of how that works, if that was the case, the employer would pay a $3,000 penalty for each one of those individuals that went out and received that subsidy. And so you're kind of probably starting to put this all together as how this all ties in for individuals to employers and all the analysis that goes on with looking at what coverage is being offered and is it affordable or not affordable and what does that mean. Hopefully this is kind of starting to make a little bit more sense as to what's really happening here and why you're seeing maybe some of the things you're seeing in the press or reading about. This is kind of the whole premise of what's going on. And this particular slide right here is becoming a lot more relevant as we sit here today than maybe it was a couple of years ago, because starting this year, if employers aren't doing this, they're going to have to start to pay these penalties in 2016 for this year. And so it's becoming really important. The individuals are having that assessed right now for last year, but employers are starting to face these penalties technically starting January 1st of this year based on the size that they're in. And so this is all having an impact, certainly, on where we're at, but I think this next slide is one of the biggest areas that is having an impact on premiums. And this applies to fully insured, what they call small groups, which right now is considered up to 50 here in the state of Wisconsin. But once 2016 hits, it's going to be up to 100 employees or less. And really what's happening is that the premiums can only be based on 4 factors, and that is age, tobacco or non-tobacco use, family status, and geography. And so within that, there's some other things that are having an impact as well. And I'm going to focus on age for a couple of minutes here. And what's happening is that currently you would have a carrier, let's say United Healthcare, and they would have what's called an age-rated chart that helps to develop the rates for all groups. And currently they might have a differentiation from 10 to 1. And what I mean by that is from a 21-year-old to a 64-year-old, I would have the rate would be a 10 to 1, meaning that if I charged $10 for my 21-year-old, I can charge up to $100 for my 64-year-old. And that's what that means, that 10 to 1 ratio. However, with healthcare reform, one of the biggest impacts to rating it's had is consolidating that down or compressing that down to 3 to 1. So what that means is that we have what we call rate shock. So I can't, as a carrier, I can no longer keep my 21-year-old rate at $10 because that would mean that in theory I can only charge $30 for that 64-year-old, and I know there's no way I'd have enough premium there to offset claims. So what's happening is, individuals, and this is just a high level to give an idea, but on average, individuals age 35 and below are having to come way up to offset that, and we call that the rate shock. Individuals from 35, I'll say, to 45 or 50 maybe, somewhere around there, maybe a little higher, are almost kind of leveling out a little bit. And then as individuals get older, we're actually seeing potentially a premium decrease for those individuals because of this 3 to 1 compression versus what could be as high as 10 to 1 in the current state or what was prior to all the Affordable Care Act happening. And so you can see it's having a dramatic impact because what used to be the case is employers were, hey, let's have a bunch of, we'd rather from a healthcare cost standpoint, the lower our employee ages, the better off we are. That's not the case anymore. We're seeing substantial, sometimes double the amount of premium for a 22-year-old, 23-year-old because of this compression of this 10 to 1 to 3 to 1. And so that's really important, I think, for everybody to be aware of as you look at where premiums and everything is going. Tobacco use is another big one. Now, not every carrier is doing this, I will tell you. It depends on the carrier, but the carriers do reserve the right to charge up to 150% of the premium for a tobacco user. And tobacco is defined as more than 4 times of use in a week. So it's a pretty loose definition, but they have put some definition around that. Again, not every carrier is doing that, but it does exist, and I think as we go forward in the future, you're going to see that differential start to happen. That surcharge does not tie into that 3-to-1 I was just talking about. That would be on top of that. So as my 3-to-1 ratio to the rates I have to develop, I would develop those, and then on top of that, I can go 50% higher for tobacco use as a carrier if I wanted to. Family status really is just no longer is there really in this again in the age and the size segment we're talking about here. If you have 100 employees or more, they're still using traditional type underwriting, but this has a huge impact on them as well because of what has to happen in these size groups. But family status really, it's a rate is a rate is a rate. So we just take, I'm single, or that's my rate, or I have a family and I have a spouse and 1 or 2 or 3 or however many children, and you add the rates together. So there is one rate for 20 and under. So if you do have younger children, that would be that rate. But then if you have a 21-year-old and a 22-year-old and a 23-year-old, as you know, you can go up to 26 now. If you have, different ages, each one of those individuals, that would be their rate for their actual age, and you just add all those together to come up with whatever the actual family rate is on that. And then geography. So in the state of Wisconsin, there's 17 different rating areas. And so what that means is that the cost of coverage might be more in Milwaukee versus Waukesha, or maybe versus Watertown, or whatever the different areas might be. But it's geographic driven, and the carriers have the right to have that as a factor in the premiums that they issue. But the biggest thing is that health status is no longer a permitted factor. And so if you are, let's say you have a group of, going forward here, 80 employees, right? Sound familiar? You would have, there would be no medical underwriting that would be done starting 1/1/2016. It truly would be taking the demographic information that we just talked about there, going to the carrier and saying, okay, this is what we have as far as our population, and they come up with a rate. There's no more 9-page applications or 3-page applications on health status. That is no longer permitted. Currently is not permitted in those employers with less than 50 employees. And starting in 1/1/16, it won't be allowed for those all the way up to 100 employees. And so this is a huge impact that's having, and I don't think it can be overlooked as we look at where premiums are and where they may be going forward. And I should also mention that it does not say it on here, but this is the same way that all the rating is done within the public marketplace. So all that, what I was mentioning earlier, all the individual responsibilities and the subsidies, all the coverage in there is done on those same 4 factors. So if you were to go out to the public marketplace and try to procure insurance, you would not have to fill out any health information. It would all be based off of these 4 factors. However, I will tell you that within the marketplace, most of the carriers are using a tobacco factor to allow them to charge more premium for those individuals. So we're getting there. Only a couple slides left that I think are just kind of important to note. Individual reporting. Individual reporting, this is in place. I mentioned this earlier, but for 2014, as you're doing your taxes now, you will have to fill out line 61 of the 1040 saying that you had coverage. There's no proof required. It's a self-attestation to say that you had it. Individuals that were enrolled out in the public marketplace actually will be getting a form that they will have to use with their filing, but if you had coverage through your employer this year, you would not need to have any proof of anything. You would just check the box that yes, you did. You can see on here that Form 8965 if you owe or claiming an exemption, so meaning that you got too much subsidy and you owe back, or you're claiming exemption to try to say you shouldn't have to do this. There's a separate form needed for that. If you are interested at all, you can look at, there's more information out there. It is one simple checkbox, I will tell you, but I think the latest I saw was probably about close to 14 pages of information on what that means. But if you have coverage, you can rest assured you can check yes, and you should be fine for individual reporting for 2014. Starting next year, though, that's going to change. You're actually going to start to receive forms. you are in a fully insured environment, as we call it, so you're going to actually receive several forms. One of those forms is going to be this form that you can see right here on the screen. It's called 1095B. This is going to come from the carrier, and if you happen to be with multiple carriers throughout the year, you would get multiple forms if that was the case for you. Maybe you're on your plan and through your employer, or maybe you switch to a spouse's plan or something like that. You'd receive multiple forms potentially. But this form is going to be filled out with your information, the employer's information, that was who's offering the coverage, the carrier's information, and then yourself and any other covered individuals that were covered underneath the plan, and what months of coverage you had in place. If you were covered for all 12 months, it would be checked all 12 months, which is the first box on Part 4 there. If you had it only for certain months, as I just was alluding to, you'd have boxes checked specifically for those months. If you've noticed over the last couple of years, the carriers, if you filled out applications, have been requiring Social Security numbers for not only yourself but dependents. While those aren't used on ID cards at all, they are still used for other reasons, and this is part of that. Because we're talking about filing of taxes and where this is all getting kind of checked in the back end, they will be using Social Security numbers, and so you will be potentially asked for that information. If they don't have dependent Social Security numbers on file, that would be why. At this point in time, they are allowing for date of birth to be used if Social Security numbers are not available. However, employers are being required to gather that data if it's not data that they have on file. That's part of the law. They actually have to ask individuals 3 times, to be specific, on getting that information. So that is something that you might see happening if you're curious as to why. That is specifically why. So that's the one form that you've received. The other form you're going to receive, this is coming from the employer. And so this form would be filled out, the parts 1 and 2, the covered individuals, that's going to come from the other form. However, the part that other form doesn't have is whether you were offered coverage and what the cost of that premium was, back to the affordability. You can kind of see this is all starting to come together now. And what those different affordability measurements that were used. And so you'll get this form starting in 2016 for 2015 filing. You'll get both this form and the prior form that I showed you. Those are the 2 forms that you'll be receiving in January. Technically, by the end of January in 2016, you can expect to receive these forms for your filing of your 2015 taxes. Again, nothing for this year if you're filing, but for filing of this year's taxes in 2016, you'll be receiving these forms. And again, depending on if you work for multiple employers or yourself and spouses, if they're working from different employers, you could receive multiples of these forms January of next year. And so the one thing that I want to just kind of close out on is, and this is always a kind of important topic, but annual limits, and I think this is important to note. There are specific requirements, and these are starting to change a little bit, and I think it's just kind of a good slide to have some reference to. For 2015, if you were on what we call an HSA plan or a high-deductible health plan, that's the out-of-pocket maximum that's allowed by the government. And if you see on there, for 2015 PPACA or Affordable Care Act, sorry, another acronym for you, you can see there's a different threshold on there, and we're starting to see this happen. Last year, those out-of-pockets were the same. Now we're starting to see a differentiation between those two, and we expect that to continue that gap to continue to widen as to what that looks like. There are minimum deductibles with HSAs, and you can see there's contributions. There's a health savings account. You're putting money aside. If you have an FSA, if you recall, last year they started to put a threshold in as to how much you could put in there. It was $2,500. That was subject to inflationary factors, so that's bumped up to $2,550 for this year. And if it's anything like other things we've seen, it'll probably go up maybe $50 a year or so. There was a carryover that was allowed potentially with FSAs, and you can see what that number looks like. But I just think it's important to note that you're seeing plan design changes that are being brought about that maybe aren't being driven by the employers, but are being driven more by the governments and what they're allowing, and the carriers are starting to set their out-of-pocket maxims accordingly. And I think that's the one big takeaway of this slide for me, for all of you, is that you're starting to see some of these changes, and this is why. It's not necessarily the carrier or an employer coming up with some magical number. It's the government's coming up with some of these numbers, and then they're just adhering to some of those regulations and numbers that go with that. So I know I covered a lot in about 45 minutes. At this point in time, and as I said, I believe there's a number of you that are in a room together. If there are questions you have, if there is someone that wants to type those in at this point in time, or if others are on your own desktop or computer, if you want to type in some questions. I know we kind of blocked out an hour. We figured it probably wouldn't take that long, but wanted to leave some time for questions that may exist. As you can see on the slide here, this is my information. I apologize. I don't know if I officially introduced myself when we started. But you can see my contact information on there. My name is Matthew Weimer, and Director of Strategic Solutions here at Diversified. And as part of that, my responsibilities are to keep up to speed as much as possible with the Affordable Care Act and what's going on, and help educate our clients and employees on kind of the effects and what we hopefully were able to accomplish for you here today. So with that being said, I'm going to stay on the line here for a little bit. Like I said, if you want to type in questions, you can see my contact information on there. If you think of anything afterwards, by all means, feel free to contact me, and we'll do our best we can to help answer those questions for you. All right, well, it looks like we don't have any questions at this time. Thank you for your time and attention today. I know it's asking a lot to take an hour out of your busy schedule to do this, but hopefully you found it beneficial. I will be actually, I modified the slides a little bit. I know we sent this over yesterday to kind of have the slides on hand, but I'll send over the updated copy of this. I also have recorded this as well, and so we'll disseminate that through. So that if you want to see this later on because you thought it was so just riveting, you can feel free to watch it again, or if you want to share with others, feel free to do that as well. So thank you for your time and attention today, and have a great day, everyone.